want to welcome you all to a very, very important webinar that we're going to be offering you today. Optum has a partnership with N.A.P.S, where we take and offer the technical assistance to be able to have these webinars. And today we have a very special, very, very special speaker today. Sue Bergeson is the Vice President of Consumer and Family Affairs for Optum. Sue has single-handedly seen the development and helped and aided in the development of over 50 years working for Optum at this point. She has taken and brought some of the most innovative programs that we have ever seen for people that are dealing with mental health issues and that are trying to get their lives back on track again. Sue is a very, very well-known speaker throughout the country, has won many, many awards for all of her work. And at this point, what I'd like to do is take and welcome Sue to our N.A.P.S webinar today.
Well, Peter, you are very lovely, and you can tell that Peter and I are each other's fan clubs. So take it with a grain of salt there, all those wonderful things. I'm thrilled to be with you. Activation is something and it's a little bit important, especially when we think about the work that peers do. We're going to look at the research that underpins that so that you can take that back to where you work and say, hey, here's why what we do works. We're going to look at different frames that you can view activation through. Again, it's a great way of being able to say, I knew I was doing this stuff that's really great and cool and important. Here's the underpinning for it. Again, something you can bring into your workplace and say, this is why what we do works. We're going to be specific about how you do activation. We're going to look, again, at some very specific strategies, and we're going to look at a few activation tools that are out there that are completely free that can be a resource for all of us. Next slide, please. So this is personal for me, and you can see 3 pictures of me up there. There's my regular one on the right-hand side, and there I am in the middle, and clearly I'm in the middle of chemotherapy. It was pretty early in chemo because I still have my eyebrows. Those seem to be one of the last things I lost. But, the quote at the bottom is from a piece of research that someone did that says, hey, we fear cancer more than just about anything. We fear it more than losing our jobs, developing Alzheimer's, having a heart attack, losing a home, being in debt, and being in a car crash. But I have to say that the picture on the left-hand side was much, much harder for me. And that is a time when I was holding on to my life with my fingernails. And that is my beautiful little puppy, Cassiopeia, who has since passed on. And I was in the deep despair of my illness. I found it much harder to live with my mental health symptoms than to live with treatment for cancer. But the good news is that in both of those cases, I was using very similar activation tools to help me get through the day, to help me get to the next piece, to help me move to wellness and recovery. Next slide, please. So when we talk about engagement and activation, engagement really is our connection to the healthcare system. And there's a bunch of words there. You can read them. And it really is something when I'm engaged when I go and see my doctor. I'm connected when I'm, aligning with my caseworker. Any of those kind of connections I have to the health system is really engagement. And engagement is hard. Let's not kid ourselves. When we're doing peer support work, sometimes we're involved in helping people become engaged in the healthcare system. It's, its own set of strategies. But I can be engaged, but not activated. And that's what we want to talk about today. So activation is when I'm actually involved in my own healthcare. So I can be engaged, but not activated. And an example of that in my own life was, I'm of a certain age, and I went to my primary care doc, who said, Sue, it's time for you to have routine colonoscopy screenings. Well, I was engaged because I was talking to my primary care, but I was not particularly activated to go in and get that done. Who wants to do that? Of course I did eventually, but it took me a while. So engagement and activation, and really Judith Hibbard, who is the big name here in this area, talked about 6 different things that we do to support activation. Symptom self-management, really critical. So when we're using a RAP plan, when we're using a gratitude journal, when we're using yoga breathing, and all of those techniques to help us through those symptoms that we're having. The second thing is really engaging in actions that support our health. So on top of symptom management, we all know that we need to be doing, healthy lifestyle. We need to be eating more veggies. We need to be eating less fat. We need to be exercising. I joined a gym this year, and I had to have peer support to go because it was so scary. But that's, that second part of activation, which is not just looking at suppressing symptoms, but helping move into wellness. And the third thing really is being involved in those treatment decision-making. I don't know how many of you are using various tools to help you make sense out of, I'd rather have this med than that med, or, let's talk together, doc, about this treatment option versus that. But we need to be engaged in our treatment, and we also have to collaborate with our healthcare providers. So, part of what we do as peer coaches is help people learn how to collaborate, how to be able to talk to their docs and talk about what they need. Our docs and our social workers and our therapists are really good at what they know, but we are the experts in ourselves. So together, we make a perfect team. So that collaboration is critical here. We also need critical performance-based selections. So we need to be brave enough and help those that we're serving be brave enough to say, this doctor, this therapist is not working for me, and I need to find one that better aligns with what I need. That is very hard to do for a lot of perspectives. It's hard to find another doc. It's hard to leave a doc, all of those things. But that really is part of activation and something we should be doing. And then finally, navigating the system, because it's extremely complicated and very hard to understand all that stuff. So as peers, you can already see how great we are at activation. But it also adds, kind of a few throwaway things that are critical. Saying, patients' beliefs, and this really also speaks to culture, their knowledge, skills, and securing emotional support are also critical here. Next slide, please. So we can be activated in some things and not in another, and that's really what the cartoon says. This guy, he's activated about making sure his sandwich is not going to hurt him, but then he goes and smokes a cigarette, right? So he's activated about some things and not about others, and that's okay. As we're working with folks, people will be activated at different times around different things. Next slide, please. So, there's some underpinning. And we talk about this work a lot, but when you're speaking to docs or other folks, they need to feel comfortable that this is based on research. And here's a little bit of research here. You can see in each of these, it says that when people are engaged and active in their own care, it's linked to better health outcomes. We're seeing in the second dot, you can see Kate Ward says, her program with chronic disease self-management really has a short-term help in increasing function, reducing pain, and reducing costs. Well, Kate's short-term is 5 years. That's as long as she tested or studied a particular group. And I have to say, for me, I'd take 5 years any time. I don't see that as short. Each one of these shows you, outcomes that say, hey, when we're doing prevention, when we're self-efficacy, when we're collaborating, when we're coaching people to be involved, all of that has better outcomes. Next slide, please. You can also see some more research on this next slide that also says that, one of the other things activation is about is helping people use the system well. When they can't figure out the system, they have worse outcomes. We know that if people choose docs using comparative quality outcomes, they have better outcomes. So the review of the literature that I've showed you really does support these things that we see, that we do when we're helping people become activated in their own care, which is self-managed symptoms, engage in activities that maintain functioning, be involved in treatment, collaborate with providers, select good providers, and navigate the system. Next slide, please. So, really the whole presentation can be summarized in this cartoon. And here's this woman, and she's throwing the ball for her dog, and they're both looking at the ball in the distance. And she's saying to the dog, how come you didn't catch the ball? And the dog is saying to her, how come you didn't throw a squirrel, right? So that's really what activation is about, finding the right motivator for those individuals to help them connect to their own self-care. Finding the right self-care tools. Maybe the right motivator and the right tools are completely different for me than they are for you. And I would assume that's the case. So as we work with our folks that we're supporting, we want to be clever and smart and listen to what they care about. We want to build that trust, start with their strengths. We're going to base it on the stages of recovery, and I'll show you that in a minute as a reminder. We're going to think this with people's own recovery goals and their personal preferences. What do they want to create in their life? What do they prefer to read? Do they prefer a computer program? Do they prefer a pen and pencil? What do they like? And then we're going to choose a few tools. We're going to curate those tools and share them with folks to help them activate in a way that's most natural for them in their own health. Next slide, please. So, on this next slide, you see that first framework that I said. This really is based on the stages of change. And the TTM model here really says that all of us, when we go through changes, go through predictable stages. It doesn't matter if the change is moving to wellness from a behavioral health condition, or if the stage is moving into a new living situation, getting married, getting divorced, having kids. We go through the same stages. We might stay in those stages for a much shorter time. We might be 5 minutes in one stage. We might be 2 years in another. But we'll still go through those stages. So Larry Fricks and Appalachian Consulting took these stages of change and laid them into a recovery framework, which we see on the next page. Next slide, please. So here are those stages of recovery, and we know that people don't go through them in a stepwise fashion. We might skip around a bit, but they're pretty predictable. And unfortunately, the healthcare system really sits in stage one most of the time. So we're in the healthcare system most of the time. People are dealing with folks when they're overwhelmed and in a crisis. Our job as peer supporters when folks are in a crisis is to help them get help to manage those symptoms at that moment. So this is not a place where you probably introduce a RAP plan at the first time. You might do some tools that help people reduce their anxiety in that moment, some yoga breathing or some gratitude work or something to help them when they're feeling panicky. You might use techniques you have in your RAP plan to manage this. But this is not the first place you introduce that. You need to get them to a place where they can get their symptoms managed. We see a lot of people in stage 2 when people are really frozen. They're disabled by the illness, and it's hard to move forward. And so we cycle between stage 1 and stage 2. And our job as peer supporters is really to give people hope in any form. It's not until stage 3 that we're really starting to work our tools and our activation tools pretty aggressively. We can do light touches in stage 1, and we can do light touches in stage 2 that offer people hope. Like something I would do there is help people access videos of other consumers who have moved to recovery, and those are available in the resources I'll show you. I might do a gratitude journal or something very light. And in stage 3, I'm going to help people identify a few things they can do to move forward and to give them some fast successes. So we want to help people participate in their recovery with some small steps. And in stage 4, that's where we're really robustly working our plan and planning our work. And stage 5 is where we're living in recovery most of the time. So I have an example of this. It doesn't really match the picture there, My example of this is when I was very ill one time. My little dog, Cassiopeia, who is, you saw her picture with the little goggles on earlier. She's the love of my life. But I was so ill that I would not let Cassie in the room. I isolated. I was not able to get to work. The idea of leaving that room was like climbing Mount Everest. And I know many of you know what that feels like. And my family really did try and help. But it wasn't until my sister Carol, who knows me really well, said to me, Sue, Cassie is miserable, and I know you love Cassie. So she's focusing on my strength. I love my dog. And she's focusing on a little thing I can do. She's saying, she is just pining away without you. She needs you to let her in and get pets and for you to take care of her. Oh, of course, I love Cassie. Oh, of course. So then she said, Cassie's not taking walks because she's so upset and she's not eating. So then I had to leave the room so that I could walk Cassie. And then I had to get in my car and go to the store to buy the food. And by that time, I had moved forward enough and had some victories. And I was able to do the next things I needed to get out of this very dangerous depression, which had to do with going back to my doctor and had to do with a lot of other more involved self-care. So I was in stage 4, and then I moved to stage 5 and was able to go back to work. So you can kind of see the stages working there. Next slide, please. So another framework to think about the work you're doing here is the patient activation levels. And you can see I've put a link there, and hopefully you can get this deck later and use these links for more information. But, the patient activation levels, the PAM, really, they show that when people are activated, have higher scores, that's predictive of their outcomes. So the more activated we are, the better outcomes we're going to have. People without good scores, people with low levels, have greater healthcare costs. So when you're going out to say, this is the reason we need to do peer services, look, when people are activated, they have less cost. When they're not activated, they have more cost. You need to hire us and keep us because we work the activation angle better than anybody does, and we will save money and help people get to a better outcome. So this research is available to you. It's Judith Hibbard, easily found. So Judith created these 4 levels, and what's interesting, I heard her the other day, and all of you can find her work online and hear her as well. And she was talking about how most of the programs we create are really designed for people who are already at level 3. We need to be thinking about our interchange with folks, the way we're designing that interchange, to work at where people are. At level 1, we don't have any confidence. We don't have knowledge. I often tell the story of Peter going out and doing a bunch of focus groups across a certain state that we thought was pretty recovery-oriented, and no one in those focus groups knew their diagnosis. They didn't know what their treatment was. They didn't know what their meds were supposed to be doing for them. Well, you got to have some knowledge in order to be able to manage your care. So that has to happen. In level 2, we're beginning to build some confidence. You need to think about how to build that confidence, to be able to understand what to do and to be able to move forward. And finally, at level 3, we're taking action. And finally, at level 4, we're maintaining that behavior. So we don't go in and expect people to jump to level 3 right away, and we don't design programs that are really expecting those folks who we're probably seeing the most to jump right in and join. Next slide, please. Well, another framework we have is motivational interviewing. I'm sure most of you have taken some training here. Just a refresher, Bill Miller and Stephen Rolnick are the folks who developed this. And they really say that people are ready for change at different points in their lives. I might be ready today. You might be ready tomorrow. And I'm sorry, people are walking by. So we have to be respectful of the fact that people are at different readiness for change at different points, and there are some things we can do to help people get ready for change. And he's saying, there are 4 levels. We engage people, okay? And what is engaging for us? Listen, 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 listen. You remember what folks have said. I've said this a million times if you've ever been in any other session I've done, but when we go in and see our doctor will wait while we talk for 7 to 11 seconds before interrupting with a solution. We cannot do that as peers. We have to listen, 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 and sit on our hands. If you allow the consumer, the peer, the folks we're working with to speak until they're done speaking, then they'll usually, on average, only speak for about 2 minutes. So we want to build that trust and engage people by listening first and keep our solutions until way, 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 way later. We want to evoke that person's perspective, and then we want to broaden that perspective and build momentum for change. And often what that means is helping people see things a little bit differently. And often a mistake that's made in this area is 2 slides forward, if you could, move 2 slides forward, I think, Peter, and then go backward. One more slide. Is this one, next slide, Peter. One more. There it is. We often do this by negative motivators. Back one, please. And negative motivators are really tempting. We want to change people's opinion about doing things by saying, if you don't do this, bad things will happen. So we find this is very common when we're looking at physical health care. Folks will say, you need to lose weight because you'll die. You need to stop smoking because you'll die. And we see a lot of literature around motivational interviewing, broadening people's perspectives, giving them knowledge so that they'll know the bad outcomes they'll expect. But, that doesn't work very well for us because although this slide is very hard to read, what it really makes the case about is that if we go with fear, we're already stressed. And most of us are when we're living with these illnesses, we're living with a whole bunch of things. And stress can be really helpful when you're facing, as we all know, a saber-toothed tiger. This is that old primal kind of way of managing things. We're built that when we're stressed, we'll release cortisol and other things, sugars in the blood that help us react very quickly to a bad environment. But if all we do is over and over and over and over and over again we're feeling stressed, which is what happens when people throw negative motivators at us over and over again, well then, we've got constant sugars in our blood. And what happens then? We have more tendency to diabetes. We have constant cortisol, which leaves us with more belly fat. We have constant hypertension, which leads to cardiovascular disease. So I would not use a negative motivator with anybody at any time. I would focus on what they want to create in their life and what they love and what they want. So we could go back a few slides. Sorry, Peter. I noticed I had this one out of sync. All right, so there's that framework 3, the motivational interviewing based on levels of activation. If you think about all these things, you're going to want to think about people's stage of change. You're going to want to think about where they are in their level of activation. And you're going to want to use some motivational techniques to help them get ready for change and be ready to embrace that. Next slide, please. What we're seeing in our peer coaching programs at Optum is something many of you may have seen before. We've got lots of different peer coaching models, and we've had really amazing outcomes. So again, as you're thinking about talking to folks about what you do that is really amazing, you can use this data to say, hey, we're seeing a 47.9% decrease in hospitalization with N.A.P.S, who's doing peer coaching through the Optum funding mechanism. Hey, we're seeing these amazing decreases in spend. We're seeing these great increases in the number of outpatient visits, which is great because it means what? People are more activated and engaged in their own care. We are doing peer coaching in 22 states. Idaho seems to be missing on this list. Next slide. What's interesting about this, really, to me, on this next slide, is the program that we're doing. Hi, I'm doing a webinar. Yeah, you guys are going to hear another conversation. We have a statement of work that shows you what our peers are doing. And somehow we lost it, Peter. So somehow, I'm not sure, Peter, if you see that we are not seeing the screen any longer.
I'm trying. I'm working on it, Sue. I don't know what's going on.
That's okay. So the statement of work that you'll eventually see for the peer coaches really tells folks that what we want them to do as peer coaches is help people identify what they want to create in their life. Help people think about building a community connections as a part of their activation. We want people to create their own recovery plans. We want people to become activated in their own self-care. And so that the statement of work guidelines really say what peer coaches do. So again, it may be smart for you to frame what you're doing around activation and to do your work around activation very intentionally so that you are being as supportive as you can to those peers that we're supporting, and you're able to say within that environment that you're working, look at all these great outcomes that activation has, and really peers are the experts at activation. So
I'm trying to get us back there. Just bear with me.
Yeah, no worries. It's all good, Peter. It's all good. So there's part of that statement of work, and you can download that a little bit later. So I'm on that next one, please, with the picture of Mary. So there you go. So often we're brought in to support people who are difficult to engage. I know in Optum we assign peer support to people with 2 or more hospitalizations in a year, which means, hey, stuff is not working for them. So we need to do something different, and we need to really help folks who are, having a hard time engaging in their own treatment. So really, this isn't all about activation. When you and you can talk about this work to others, and you can really look at the way you're working in the frame of activation. So we're doing the work of listening carefully and responding. I was just talking to someone who said, frankly, it took probably 3 months of going back to that person before they would start talking, but being persistent and listening carefully and finding something that they would talk about. Finding out what those motivations are and building that into your recovery goal, not a treatment goal. So the next one is aligning the members' own motivation and recovery goal to the treatment plan so that the reason we're doing treatment makes any sense at all. The next one is helping people prepare for their visit with their doc. We should be doing that so that, remember those 6 things in activation, to really be an equal partner in care. So helping people prepare for those visits and identifying where they are in the stages of recovery and giving them those recovery tools. Next slide, please. This is the one that came early, so next slide after this. All right, so another way of framing that is to identify their strengths and build on those strengths. What do you care? What do you love? We have lots of great stories of work that our fellow peers are doing out there where they've really discovered a unique and interesting thing about that person. I remember hearing kind of recently a story of someone who, Pam Binkley was talking about this. She discovered that one of the folks she was working with had a love of the Weather Channel. So she made a part of what that person did, and this happened to be a group, was to kind of do the weather report, and that gave him an in. Gave him a way to enter the group in a way that was very pleasurable for him and broke down a lot of those barriers of fear that he had. So building on those strengths, helping people develop their own recovery goals, help them use that to shape treatment and self-care choices. Provide that meaningful education. When I was at DBSA, the folks from Harvard sent us their consumer brochure. We're going to explain mental illness to you. And, I'm a reasonably smart person. I don't know that I'm the smartest one on this call for sure, but I'm reasonably smart, and I could not understand even the first paragraph because these are guys from Harvard. And they had their own bizarre language. And when I went back to them and said, look, this is not particularly patient-friendly, they were all, oh, no, it's completely clear. So, we have to, provide meaningful education that helps people understand these complicated topics. We want to put those empowerment tools in people's hands, but we want to be very smart about that and think about their level of recovery, their stage of activation, their preferences, their strengths, and the goals of the member. And then we want to help them access community programs, and we want to help them identify their own triggers. And, the RAP plan is available. Mary Ellen Copeland does a great job. We have partnered with her, and the Optum RAP plan is up on Google Play and in the other store. And you can download that using the code OPTUM, capital O, to have your own RAP plan on your phone if you wish. And then you want to look at their whole health. So next slide, please. I was just doing a session the other day. 68% of us have co-occurring physical health issues. So as a peer, we really, really, really want to be helping people with those issues. And one of the great ideas folks had told me the day before yesterday in Kansas is that instead of just doing a sitting face-to-face support session, they're actually walking together and getting some physical activity together, which I think is a really great idea. So here are some of those activation tools and strategies. I realize those links are going to be hard for you, but if you go to something called liveandworkwell.com and you look on the right-hand side of the page, there's a little menu. You can open up each of these tools, and they're completely free for you, and you can download them and use them with members. These happen to be the Optum tools that we've developed. We have some great toolkits with lots of different things in them. We have some videos. Peter features in these videos, helping people if they're just diagnosed. We have smartphone apps. We have links to online and face-to-face groups. We have our video stories of hope. And that's really important if you're helping someone who just has a hard time believing they can move to recovery. Hearing from a lot of different people is really empowering. And you know that your own story is super important to people, but hearing from a lot of different people, watching these stories can be very empowering for folks. We also have the activation tools. Next slide, please. Some other great tools that are research-based and are really excellent that you could be considering, all of the support groups. I really like the Facing Us site, which is an offshoot of DBSA. It has symptom trackers and health trackers people can use. It has people posting their own strategies, and you can click the box next to each strategy that appeals to you, and then print. And then you'll have your own toolkit of strategies that you like to use based on all of these great ideas from folks. Of course, the RAP plan, Super Better, I like to talk about that. Purple, middle of the page. Super Better is an online game approach. I don't want to be better. I want to be super better. And you create your superhero name, and you have your allies, and you set up your enemies that you want to defeat, and then every day it'll give you certain things to do. Like one day it told me to go outside and hug a tree, which gave me exercise, and it made me laugh. And, those kinds of things add a little sparkle to your day and help you move forward into recovery. So I highly recommend Super Better. A lot of other things on this page you can look at. Next slide, please. So these are some other great resources, lots of things for addiction recovery. I always look at the mindful meditation stuff. There are great meditation sites for new beginners. audio files. There are lots of apps you can download. We have a listing of apps we like. We also have a guide to mutual aid resource link here from Faces and Voices that really gives you a whole library of things. And the cultural activation prompts I like a lot for all aspects of behavioral health. You know, I am a very boring cultural background. My parents come from Sweden. This is pretty boring, I have to say. So I thought, you know, the cultural activation prompts won't be all that interesting for me, but, you know, they were. Because what it taught me is that going through them helped me think through how the culture that I learned from living in this very Scandinavian place where you don't talk about your feelings, where, you know, you don't, you're very buttoned up, helped me realize that there are probably things I'm not saying to my doctor, and I need to let him, in one case, her in another, know that that's going on with me. So that's a great tool that I highly recommend for folks to help them be clear about what their culture, the impact their culture has on health, and communicate to their docs. Next slide, please. So as we get to the close here, I want to do a couple things. You can see this quote from Rick Berkel really says, in all aspects of health, self-management should be at the heart of what we do. So these days we're talking a lot about integration of health and behavioral health, and those of you who are working in that space, the self-care tools and strategies we just went through are just as applicable within health as they are in behavioral health. And I know that we're all super busy. I know it's hard to add one more thing to the work that we do, but I think this is really important, and I think framing it and having those tools to share with members is really critical for moving the needle for folks as they, you know, really do their own self-care and really become empowered. So I want to tell you one more story, and this is one where Peter features prominently. So at Optum, which I don't know if you know, Optum is a very large managed care company. It's the behavioral health arm for United Healthcare. So I was in a work group where folks were trying to find solutions for kind of the top 20 spenders in the behavioral health system. 20 people who, year over year, were spending the most. Now, of course, I was there because those 20 people were living lives of intense pain. And we've got to find another solution. And so, you know, what I did, which is what every single person on this phone would do, is say, do they have peer support? And I'm going to call her name Mary. Mary was someone who every single year was in and out of the hospital. The best she could do was stay at home for 1 or 2 days in a row. When she got out of the hospital, she would threaten to jump off a bridge. She would lay down in the middle of an intersection. She was completely hopeless. And it was a small state. She had been to every doctor and every system in that state. And the doctors no longer knew how to help Mary. So let's try peer support. And so Peter got out there and he found the perfect organization to provide peer support for Mary. And Mary has now been out of the hospital how many months, Peter?
We are at over 9 months at this point, so.
So this is a woman who, for 5 years, could only stay home for 1 or 2 days. With peer support, she's out of the hospital over 9 months. Peter did the math on this, saved over $171,000 by having peer support for someone who everyone else had given up on. So part of the magic here was really around that activation, listening, developing that trust, helping people talk about what they want to create in their life, use activation and self-care tools to support Mary into this new, brand new life. So a really amazing outcome. Next slide, please. So when I was at DBSA, previous to my time here at Optum, I did this very large survey, and that was in any of my WebEx way. When we did this survey, and over 2,000 people responded, I expected the answer to this question, I want the healthcare system to, would be have better medication, treat me more respectfully, because those were the things I was hearing. But as the surveyors analyzed all the responses, this is what people want from us. They want hope. So if we do nothing more and nothing less than offer people hope, we will have done an amazing piece of work. Next slide, please.
Sue, you've done a wonderful job, and I want to thank you very, very much. We're now into our question and answer period. I'm going to ask people to please use the chat function. And Rita, I'm going to need your help with the chat function. So I'm hoping that you're going to be able to read them. If you would take and direct your questions where it says, you can do it to everyone. That way Rita will be able to take and see what your questions are also, and we can answer those questions. I'm going to try going into the chat feature, but there's a couple more slides that I need to think about.
And I'll be happy to help out, Peter. Thank you.
Thank you very much.
Yep. So the first question is from Wendy, and she asks, the information emphasizes the interpersonal factors that influence activation. What are some of the systems or community-level factors that can affect activation? Well, certainly on the positives, all of us have community resources and supports, and we need to be thinking really creatively about that. You know, the other day I was talking to somebody, and you know what he loved model planes. And so we spent some time finding a model plane club. That's a community resource that can support activation completely outside of the mental health community. I know, again, when I was very sick, you know, support groups were great, but, you know, I got a lot of time to fill here. And so I was, again, picking up on my love of dogs, and I was walking animals at an animal shelter. So using the community very creatively. On the minus side, you know, I don't know about you, but I do not hear folks coming away from their doctor's appointments and often their therapy appointments with activation tools. I rarely hear, and again, back when I was at DBSA, our referrals were not ever coming from therapists or doctors. They were always coming from word of mouth. So, you know, on the negative side, sometimes our systems are not thinking about activation. They have this, maybe you take a pill and you'll be all fine mentality, and taking a pill can be extremely important. Doing the work you need to do in therapy, extremely important. But we also need to do this activation. So that's where I think peers are really excellent and important, because the system is not particularly helpful around that. It also is challenging when you're trying to partner with your healthcare provider. You know, understanding that part of activation is partnering with your provider, so the system does not allow you a lot of time. That's why you need to prep in advance. You need to maybe role play with your peers, peer-to-peer, so that you feel confident going in, and that you're ready with something to do. So those are all maybe some challenges and maybe some opportunities.
Rita, do we have any other questions in the chat function?
We have one from Leon in New York, and he said, here we're having care managers access recipients before they receive their services to develop health and recovery plans. How would this be done so that we can elicit the recipient's activation into services? So what I think you're saying is care managers are working with the member about their recovery plans before they access services. Is that fair, Rita?
I think that may be what Leon is saying.
Okay. So certainly if we can get to those care managers and do a little training on activation, again, when I'm dealing with pretty much anybody in the system and I'm talking about this, it seems brand new to them. So helping them really elicit strengths as a part of that treatment planning process, elicit the person's own motivation for change. You know, when you talked to Pat Deegan about common ground, Pat will often use the example of my recovery goal is to work at Pizza Hut. Now, that is not the way we generally talk about recovery goals in a clinical setting. So helping our care managers reframe and use the person's own motivation and put that as the recovery goal instead of my goal is to not feel so bad. My goal is to reduce symptoms. So, reframing that goal to a real recovery goal, what I want to achieve in my life, built on strengths, is the first step to activation. Because then, another piece of training that I would do and I do internally at Optum is help people think through what activation resources are out there. Peter does an ongoing webinar to our, sorry about the noise, ongoing webinar to our care managers that teaches them new recovery resources that are out there. So they have a whole toolkit so that folks have that toolkit and can begin having the conversation with consumers around that. So it sounds like it's a combination of training and a combination of ensuring that the treatment plan is really recovery-oriented and based on the members' own things they want to achieve and not simply a cessation of symptoms.
I see that somebody was looking for Sue's email. That's why I brought it back to the slide again so that you can find how to contact Sue if you'd like to. But again, please be aware that the slides are available through INAP. They will be up on the website for people. So please, feel free to access this. There was a lot of information that Sue gave you related to various supports and various programs that people can be offered so that they can find their path to recovery. Rita, were there any other earlier questions that I haven't seen on the chat room?
I'm going back to take a look, but I just wanted to really, first of all, thank you, Sue, for coming and joining us today and giving us this wonderful information that all of us should be very attuned to, and especially thinking about how we make the case for peer support, how it really saves the system, it saves money, and it saves lives. So I just wanted to ask if you had a comment about what peer supporters themselves can do to really make the case for peer support, especially with funders and financial people.
Well, to me, I've given you a lot of the things you need to make that case. And, when you're talking to a funder or when you're talking internally in your own system, I would create a one-page document that says peer support is not only good to do, but it's good business. Here are the outcomes that we have seen. Peer supporters really are the experts at activation. Here's the research behind activation, and here's the outcomes we see when people are activated. And you can make that case to current funders and current bosses, but this is also a really good thing for those of you who are interested in moving to that integrated care place, looking at both health and behavioral health, because this makes a case cross-illness. And a lot of this research is cross-illness, and that's, can speak very well to folks who maybe are from a medical background and don't really understand behavioral, but they will hear that message about activation. And, a lot of this data is around both behavioral and medical integration. So that's what I would do. I would create that one-pager. I would be ready. I would frame my work in terms of activation. I would show very specific outcomes, and I would put a little bit of the research in there. Thank you.
So I think you answered part of this question, but let's take an answer question. This will be our last question, folks, because we are running out of time. But this is from Colleen, and Colleen is asking, how can we support professionals to rectify the medical necessity paperwork with this activation method?
Well, paperwork is a really big problem, but the thing that I'm seeing as I'm scanning for trends is that there's an understanding that we're getting in our own way around documentation, and we are seeing some changes at pretty high levels rethinking what documentation is absolutely critical. So I think we're going to see a change in that. I think that some of the things coming down from the Affordable Care Act, some of the ways that we're, as companies needing to be more nimble, some of the ways that managed care companies and Medicaid are changing, I think we'll see a change in the burden of paperwork coming down. I also think that when you look at most paperwork and you're looking at, what is the member's own goal and what are the strategies, activation has to be a part of that. And when folks are creating those plans, if they understand the role of activation, and again, we can be educators around that issue, then they're going to be putting in those strategies as far as part of their plans. So, 2 points. We can weave it into the paperwork as it stands. If they understand activation, I believe we'll see some changes in the burden of paperwork coming down. And actually at the Carter Center today, working with the board as they're looking at trends into the future, and that has just reinforced that perception.
So I can't thank you enough. You have many, many positive comments in the chat function about how interesting and how important this work was and work is, and how grateful everybody is that you presented this to everyone. So on behalf of I.N.A.P.S, on behalf of the people that are participated in this webinar, and there's many people that participated in this webinar, I want to thank you very, very much, Sue. You did an outstanding job. And considering we had a couple of technical challenges, we sure made it through, didn't we?
Well, Peter, once again, you are my biggest fan club, and I am your biggest fan club because you are amazing, as is everyone on the phone. So thank you for participating today and allowing me to share something I'm really passionate about. And I welcome any emails. So talk to you all later. Thanks. Bye-bye.
Thank you very much, Sue. Have a good day.
Thank you, Sue. Thank you, everyone.
Rita, take care.
Yep. Thank you.